You're not on the hook.
Okay.
You're all good to go. So
Thank you, Peter. And I think, I'm not sure, unless L is joining. I'm not sure or not. Hi, Barb.
Hi, everyone.
Hello.
Barb, I thought of you the other day, and why did I?
Because she's a wonderful person.
Well, yes, absolutely. But I think it was about, I was at a caregiver symposium where a gentleman was presenting, he was a doctor, and he was presenting his book that he wrote about his father's Alzheimer's. It was called My Father's Brain.
Mm.
And he was talking about Molst, and he was saying how he believes that people can have their decisions made and whatever. He goes, but to me, everybody should have the ability to change that at any point, which we know they can. He called it, oh, what did he call it? The something phase. Oh, I can't remember.
I will have to get the book. What is the book?
The book's My Father's Brain, but I think
My
this was
Father's
just
Brain.
part of him speaking. And I took notes, and of course, my notes are at home. Because I wrote this one phrase that he spoke about where he said that, I know what it is. Where he said that this was if you have put someone in charge of your well-being, like your medical proxy and things like that. He would like to be able to, he would like it to be that I can set those, oh my God, I can't without my notes. You can set your goals of care, but really at the end of the day, if your loved ones are intervening and saying, well, this is what my father would want, right?
Mhm.
But now your father has Alzheimer's. So which father? Because my father with Alzheimer's loves living like this, and he's happy and joyful. But my father before Alzheimer's never wanted to be a burden to his children. So how do you figure out that you may have that he signed as a person without Alzheimer's, but now why should we honor that with a happy person with Alzheimer's? It was very, it brought up a lot of questions in the
Mhm.
room. So, and that's when I was thinking of you.
Were there any ethicists in the room?
Any what?
Ethicists, bioethicists?
No,
No.
no. So, but
It's a question that comes up in different conversations with Molst and who has the overarching authority. But that situation specific to my dad is living his best life with Alzheimer's.
right.
It is an ethical dilemma.
Yeah. And he even said it himself. He said, so if I have Alzheimer's and my children, know that before Alzheimer's, I said, please don't prolong my life. Don't, no heroic life-saving things because I don't want to be a burden. But then you're at that point and your children are saying, but we don't mind. Like that's, he said, so which one of
Right.
me do you listen to?
I think attorneys would have a very clear pathway
Right.
as to which voice you listen to.
Right, at 100%. But it was
Probably
something,
the individual signature.
yes. And it was something that I never even thought about. Like, okay, yeah, you have literally two different people,
Mhm.
So anyway, enough of that and we'll move forward. But you were in my thoughts going, oh, Barb, I wonder what that's all about. So thank you for getting on today. And as you all saw, we kind of switched this to an action committee as opposed to an advisory committee. Mainly because I think I think we have a few more things to get concrete on before we present to the advisors of this committee, because I feel like if I'm still confused and I'm still kind of reeling through a number of things that we may all be in some way, shape, or form, and how do we, we've gotten to one point where this is champion care, and maybe it was me who kind of has swayed from that back to it, away from it, back to it again. And so I think that the PowerPoint that Melissa put together would be something to kind of follow today and just understand maybe where we're going, but then, figure out what this actually looks like. It will entail, a meeting with maybe Elle and Eugene. And, Eileen, I want to say the retreat was amazing. Eileen did the Pediatric Palliative Coalition retreat, and it was so interesting. And her name right now is gone out of my head. The attorney that presented.
Shelley Jabal.
Yes. Who was like, that's like exactly who we need right now to say, okay, what if this? If we're looking for this, then this. If we're looking for that. So Eugene is actually going to reach out to her to see if maybe we could just get some time with her. But it was so nice to be in the same room. So that was great.
Thank you.
But like, so a couple things have come up, and can we just pull up the PowerPoint from today for today?
Peter, is that you?
Can you say that again?
Are you able to pull up the document?
The one that you shared with me?
Yeah.
Yeah, I can.
Okay, thank you.
And Melissa, I know you're waiting on things for me. I will get those to you. I'm so sorry.
Oh, that's not a problem. Not at all.
Can we just, who is iPhone 4?
I don't know.
That is me, Tony, and I transitioned to my phone.
Oh, I just saw your, I'm sorry. I just saw your
Nope, that's okay.
email. Okay. Okay, so if we go through like today, what we've put together, like with, today's themes, can we go to the next slide, Peter, or do we have control of it? I don't know.
Peter does.
Okay. So from a nursing perspective, I think we all know and we all agree that from a nursing perspective, we are lacking in, well, I think this state is lacking in the amount of nursing in general, right? So the lack of nursing for pediatric, palliative care, and hospice is, is high. The lack of shift nurses, which, I'd like to say, well, they're kind of like palliative and hospice nurses, but again, they're really not. They're shift nurses. There's a general consensus that the reason why there are not enough of them is because the pay has been too low. So that's an issue that we know. These are the things that, we know. We feel that there probably are not enough, and Eileen, keep me honest here, enough of training resources, meaning places to go and actually do a rotation through the hospice in general, let alone pediatric hospice and then pediatric palliative. I think we probably have more of an opportunity for pediatric palliative for people to train in than we do pediatric hospice. But that, again, I feel we are lacking. I think we have great nursing programs, so we know we're not lacking there. It's just how do we get people up to speed, with experience in pediatric hospice and palliative care. And Eileen, if you don't mind, because I know you mentioned something at the retreat, that there has been something mandated in nursing programs that have to be included. And I don't know, I can't remember what it is exactly or when that is official, if not already.
It may be on the next slide, I think, that
Oh.
references that, Tony Ann, the nursing piece. And my apologies,
on.
I shorted so there was a slide that focused, Peter, maybe it's the next one. Yeah.
Okay, so nurses training, curriculum, nursing programs now must include, so that was me guessing. So I wasn't sure if that's exactly what it is, the curriculum requirement. So if you could fill that in, that would be great.
Sure. So for our nursing education accreditation, there is something called the new essentials. And for a baccalaureate program, so our schools of nursing that have a BSN program, and if you're accredited by AACN, the American Association Colleges of Nursing, and CCNE, the recommendation actually comes out of the American Association Colleges of Nursing and Hospice and Palliative Nursing Association. We've identified, so our nursing organizations have identified 4 populations that all student nurses should be exposed to and have education and performance-based behaviors. So students should be able to demonstrate certain competencies. And one sphere of the 4 is palliative care and end-of-life care.
Okay.
So our governing bodies for nursing education have recommended that our future workforce have this education as a generalist. Now, it's not specific in detail of what that looks like, but every school of nursing is going to have to demonstrate the outcomes. How do we assess student nurses regarding palliative care and end-of-life care? What does that look like? What knowledge content have they had? What simulation activities have they had? What clinical exposure have they had? And it's across the lifespan. So it's not just pediatric, it's all age groups.
Mm-hmm.
So that has started. This requirement is actually several years old, but across the nation, schools of nursing are at different degrees of implementing the new education. So it's not enough to say they've read a content module on palliative care. We actually have to show assessment and evaluation. The students have to demonstrate their readiness to take care of patients with serious illness. So that's in our favor. The
Yes.
future workforce is going to have generalized palliative care education.
Okay, which is amazing.
Mm-hmm.
Can I ask you, is when you say like nursing programs that are the BSN or certain accreditations, does that make the group of those programs smaller than just the general group of nursing programs in our state? Does that make it smaller for programs that actually meet all the criteria of that you were saying? Am I making you confused?
No, I think you might be getting at, say, a 2-year associate degree level nurse. I could look into what kind of exposure they have for education, but any of the nurses, the colleges here that offer a baccalaureate, a 4-year program, they
Okay.
will have the same requirements.
Okay. Okay. I love that.
Hmm.
Okay, and it's palliative and end of life. So that's something that, we're hopeful for. And then when nurses go into, well, so they will have had it as a bachelor in a bachelorette in a baccalaureate program. When they go on to a master's, like in looking for a nurse practitioner, does that mean they've fit the criteria already and there's nothing really further as an APRN to do palliative care and end of life? Or does,
So that is still unfolding.
okay,
The the essentials, our map of nursing education recommends that the graduate level build upon undergraduate education, and so therefore one would say all APRN programs should be embedding palliative care and serious illness care.
okay,
Yet I don't think that's the case just yet.
okay.
It's really spelled out clearly in the undergraduate programs.
Hmm.
It might be a matter of catch-up time.
Right.
Tony Ann, have you heard of the palliative care education LNEC?
Yes.
Okay, the LNEC leadership says the same should be true for APRN education.
Okay.
So I think the goal is to get there. I'm uncertain at this point in time how many grad programs are including it in general education. Certainly, there are schools of nursing that have certificates and um, a real um, track or
Mhm.
subset of palliative care education, but not all.
Right. But it's a good thing to hear that maybe it's on the road to becoming that because, I think that's, greatly needed. Um, all right, and not to throw you off, Peter, but could we go back to the first slide? So this is how my brain has been working like for the past month, I would say. Um, okay. So then we look at, so we've gone through that with nursing and we even went further than this one bucket, but then we look at insurance coverage and it's Medicaid versus private payers, and then the Katie Beckett waiver and the impact. So when we think of, and Shelley spoke about it at the retreat, when we think of a insurance mandate in the state of Connecticut that would mandate private insurances provide a pediatric hospice or palliative care benefit, but also concurrent care. So, we have to be able to, the private insurers will cover the concurrent care and then also provide a palliative and hospice benefit. Um, that was one thing that she said, look, and is it, are we going for pie for the sky? But she did say you can go for a mandate with private payers. So that's one thing on our list. Do we entertain that? And then what does that entail? Which Elle has kind of put together in an email that I can share with everybody after this call, where yes, it could be a change in law, but we're asked to come up with recommendations of how to make this better, and that's a recommendation. That's going to be a recommendation.
And Tony, and to dovetail on that, through our coalition, I also talked to other state coalitions.
Mhm.
The state of Illinois has had one such mandate. They have successfully passed a private payer mandate. And I talked with Elle and Eugene just via email.
Mhm.
Perhaps their group, the Yale team, could talk with the lead people in Illinois
Mhm.
to see how that was enacted.
Right. Okay. That would be great. And in her email that I'll send to everyone, she said an insurance coverage mandate for private payers would require new legislation.
Okay.
So,
So Tony Ann, I'm in the car, so I'm sorry I can't raise my hand.
no, please go ahead.
But as I think about that and adding legislation so that there's parity across the reimbursement source, you might want to engage other stakeholders in that discussion. For example, the insurance law.
Barb, we're losing you.
Hang on, Barb, because you said the most important part and we lost you.
Lobbyist. So that, and they're, sorry, I'm going through a dead space. How about now?
Yeah, now it's good.
So can you hear me now better?
Yeah,
Yep.
we might want to include who?
The insurance, the lobbyist from the insurance industry.
Yes. And just so you know, we do have a call out and a contact out to her.
Okay, great.
Yeah, go ahead.
And I can see what I can do on my end if any of us speak to her to see what we can do to facilitate that connection. Because
Okay.
the greater buy-in you can get from everyone, the better outcome obviously you're going to have.
100%. And that's why, advisory committee to action committee right now is really like, I just want to be really well prepared. So thank you so much for that. And more to come on if we do get in contact with, and she can provide some help to us. Further here, we have the Katie Beckett waiver and impact. And on Elle's, when we talked about, I asked Elle about the Katie Beckett waiver, and she said it would be increasing the Katie Beckett cap. And this would require either legislative action to authorize DSS to serve more children, or converting the program into a state plan amendment, which would get rid of a wait list. So, and she also put in that it appears that Connecticut has been researching this option, and she gave me a link. Like, she's another amazing one. And it's a whole thing on a research report on the Katie Beckett. Did I lose you guys?
Nope, we're here.
Oh,
Just
okay.
listening politely.
I just lost my screen. Okay. It's a whole thing on the Katie Beckett program in select states. So that's another thing that I can share with you all, and we can, have Elle or Eugene maybe speak to more of that. Then she said something here, because I was like, where would we direct the need for increasing the number of recipients on the Katie Beckett waiver, and how do we proceed to have a mandate for payers? Those were my questions. And she responded also with,
Tony Ann, it's on slide 4, I think, if Peter wants to jump to that. There's
sure.
so in that way you can.
you know what? And
Yeah.
Melissa gave this to me to review that I've done like 3 times already. And, okay.
You're there.
Okay, you're the best. So increasing the Katie Beckett waiver and increasing DSS funds. So this would be directing the need for increasing, like we said, the number of recipients on the Katie Beckett waiver would require legislative action to authorize DSS to serve more children, or converting the program into a SPA, which is the state plan amendment, which would get rid of the wait list. And again, I'll send you the link for the research that she's talking about. Then, assuming that federal grants, such as Title V block grants, are not a viable option right now, I believe that increasing DSS funds would require lobbying the legislature unless DSS is willing and able to set aside funds out of its current budget. You go, Regina.
Well, which I think in this political climate, that will be stretching.
Oh yeah, no,
Budget
you know, and all of this, it's so funny because Jessica Pope and I had a phone call before we got on the meeting, and you know, she was talking about how everything right now, right, is like such in flux because of where we're at federally. So yes, I totally appreciate that.
And Tony, and just to that point, Jessica has had her hand raised politely, and maybe she's able to weigh in on that. I don't know.
Oh yeah, I see. I can't see her. Oh, there she is. Hi.
Hi, thank you, Melissa. I mean,
Sure.
I'm really just, I think speaking, and I think maybe this is something that you'll continue to expand on, but when it comes to the mandate for private payers, I think that is an excellent way to put energy towards having consistency. I think when having experience right now just in the field or in the trenches with getting access to concurrent care for kids, Blue Cross Blue Shield, very, very concurrent care friendly, but typically will only cover 80%. We have other private insurance policies that, you know, are not as consistent in what they are willing to provide. And so a lot of that is waiting for that feedback before we're able to move forward. So I think having a mandate in place, whatever that ends up being, will help increase the consistency so that people know what they have access to and what that's going to look like from a coverage standpoint. So even if it's, yes, certainly starting at the ground and honoring hospice and concurrent care just as a benefit is incredibly needed. But I think even expanding upon that and really outlining how much of a benefit are we willing to honor in these cases and to what age are we willing to do that? Because the other area of inconsistency is that sometimes they want to align with the Affordable Care Act and look at 21, but several say we see the financial benefit of concurrent care. We see that these young adults are not going into the hospital as often, or that they're requiring less support or less supplies or less DME, et cetera, et cetera. And so we're willing to increase that age up to 30. So also just having a good jumping off point that you know across your state that you will be able to offer this service up to this age and what that will look like.
Tony, and you're on mute. Sorry.
I said, thank you so much. I agree 100% and thank you for that. I called her my pediatric hospice and palliative care guru today when we were on our call. Can we go to the next slide? Barb, can I have you, Melissa, can I have you kind of go through what this is and how it was put together?
Sure. So I found this, I believe it, I don't know exact the source. It might have come from either the state of Michigan's website or a palliative care website that articulated, you know, the services. Essentially, what this shows is all the different places that families can get access to these services, essentially. The issue with this is it's a bit of a scattershot, which means that families would go, okay, well, where am I going to get, if you look at just respiratory support, well, you get oxygen from hospice services, but you get ventilator from concurrent curative services. And one of the goals of, I think what we want to do is put together a footprint so that families can get everything under one umbrella, even if we know some of the sources might be defined by the medical definition, but the families don't have to worry about the navigation of this. And so the challenge right now is I don't have anything for the state of Connecticut. I just pulled this up and it looks like a reasonably good table to show inconsistencies. And I think in writing the report, I think it tells a story basically of the confusion of what families could face in terms of obtaining very critical services and support and care for their child. So I don't know who on this team might have this information. And really what I need to do is have a check the box approach to show what Connecticut provides and what are the sources from it. And I'm guessing it's going to look somewhat like Michigan, that some will come from hospice, some will come from concurrent care, some comes from both. But I think it tells a pretty powerful story to show the confusion that families could face when trying to get the right support for their child.
I think what's difficult about this chart is, I think what I personally struggle with is that a lot of, and I understand, I think the purpose that they were really getting at, and that you just highlighted as well, about really how these partnered services help cover everything, right? But I think what's difficult is that technically concurrent curative services can cover everything on this list. It's really just what would delineate over to hospice if hospice was involved concurrently. And I think that's where some of that confusion could certainly happen, because as a parent, if I came in and said, well, I know that my child's going to be needing narcotics for pain, this chart makes it look like the only way I could get narcotics is through hospice. But we know that narcotics can be provided outpatient through like the provider that's managing that pain, and them not be on a palliative service. So I think I love this chart. I think I would be confused coming in as a parent thinking I can't get this unless, when in reality, I think this is more of like the delineation of care in partnership. Is that making sense?
Yes, it is absolutely. The question is if a parent, so let's start from the top. The child gets a diagnosis. The parent may or may not know what services are required. We know that some of the direction on this might come from their primary care physician, might come from their, for example, their oncologist, pediatric oncologist. But how does a parent, for example, we've heard stories from this group, a child will go home, well, they don't have ventilator support. So how do they get that? And the goal, I think, this should tell a story of the complexity of who owns what decisions, right? But the complexity of this is, how do parents know who's going to be responsible for helping my child? And maybe there's a different way to show this. So, for example, kind of a decision tree type of thing, versus a table with boxes checked. But I think what I understood from a variety of comments that people have made is sometimes parents have to hunch out their own decisions. And it isn't as easy as, well, okay, we know they're going to get X, Y, and Z, and then it's going to get handed off to the next person. But it really ends up the parents kind of say, I don't have this piece of equipment at home. Who do I talk to? Oh, well, you have to go here. So I think what we're trying to do, this sounds way oversimplifying, is create the easy button approach. So a parent knows that within the scope of care that their child's going to need, all these resources are going to be available. It's going to be relatively straightforward how they get access to it, regardless of who provides it. They're going to get the handoffs and the coordination. So maybe it's a way the visual isn't as helpful just to drive home the story. And I'm certainly open to whatever people think is the right way to provide some sort of explanation.
Yeah.
I think the goal is for the assembly members to understand this is not easy for families.
Yeah.
And so there's a complexity to this.
I like the idea of a decision tree. And I think maybe what tripped me up personally was the column of both hospice and concurrent curative services. Because theoretically, a lot of those things could be checked because they are going to be managed by one of those two. So maybe even just getting rid of that line and really showing this is typically how we're having to delineate and partner and care on a lot of these items. Because it's also, unfortunately, so individualized based on the needs as well, and what was already in place and things like that. So I think just to help tell the story, it would be good to simplify a little bit. And the idea of a tree, I think, certainly helps. I'm even looking at like tube feeding for nutrition. says both hospice and concurrent curative, typically tube feeding is going to be curative and concurrent. That isn't necessarily going to be managed by hospice because that's life sustaining. So also just kind of looking at some of those things.
Okay.
Right, and I think, and Regina, I'm going to get to you in 1 second. I think that, yes, I totally agree, Jessica. And so where we struggle sometimes as a hospice provider, so you can imagine how difficult this is for a family, is where does hospice pay for it and when does it remain on concurrent care and it's being paid for separate from hospice? So, and the funny thing is, and not the funny thing, but when we look at like narcotics and analgesics, well, hospice might be paying for some of it if it has to do with the terminal diagnosis, but if it's for other things, then concurrent care might be paying for it. So you can actually have it split, like even when it's just general columns of, narcotics and things like that. So I think this is really good to also show. I like the what did we say? I like the different format to show, because that also we get confused. Like we have to think sometimes, okay, wait, guys, that's concurrent care. So we're not billing for that, or I mean, not billing, we get a per diem rate, but that has to be billed separately. And the struggles that we go through as a provider to even get someone else to bill for it. I mean, you can imagine then what the parents are going through. So yes, we can tweak this slide, but I also like to go to the other format that you guys just spoke about. Regina.
So, so yes, I have a question and also a thought. Now, the question is, who will be the audience for this resource? Is it for providers or for family and parents? And then the thought is, Jessica, to your point, should we add a column that, addresses the condition or the disease so that, once it's read across, they will know what, the treatment or the resource is referring to. And again, to Melissa's point, I think this, snapshot, diagram of the point system, makes it easier to read too. So that's just my thought.
Can I just jump in for a minute? I think that there's two things to address your question, Regina. I think there's two audiences for whatever we're going to put together eventually. There is going to be the caregiver. The provider team. They're going to need to have this information. So there's probably going to be a different approach for them, because there's going to be things like insurance sources and coding and medical definitions and things like that they have to understand. To your point, Tony, and that hospice covers this, but there's a portion that could be covering that. So I think the care team will have a different snapshot. I think the families need to have something simple to know where the sources are, but they shouldn't have to worry about all the individual items. And I think, I mentioned to Tony Ann earlier, in my prior work role, we created a platform for our clients, which were firm leaders. They didn't want to know all the sausage making. They didn't really care how we got there. They just wanted to know what's there for me, and they wanted the easy button. And if I call Melissa, she's going to get me to the right person. Now, that's a way oversimplification to what we offered, but and also how it worked. It also would pertain, oversimplification to, this type of care. But I think the goal for families is to simplify their ability to get access to the right resources and the right care, and understand, the payer options and things like that, so they can concentrate on their child, said simply. I think our challenge is the sausage making in the background. How does that work? How are we going to parse that out? How do we carve out different pieces for different groups or providers? And that's very, very complicated. I'm certainly not suggesting it's a simple approach, but I think for the family side, we want the easy button. On our side, we have to deal with the complexity of everything in the back end.
I just see Barb up and then, and then Eileen.
Thank you, Tony. And my comment is going to be very quick. And I agree with everything that everybody has said, but most importantly for me, doing a graphic or some kind of table helps honor Ms. Torello's comment early on in our work that families, when they are going through this, need something that helps guide them so they don't have to do the real hard work of working with insurance companies, working with healthcare providers. So we honor the fidelity of her comments by moving forward with a care map or some kind of, I love the concept of toolkits with whatever we do. So I'll stop there. Thank you.
Thank you, Barb, and I do agree, and I think it would be good to go by disease, right? By the different diseases or genetic anomalies, and I know that could be a lot, but Eileen?
I just want to give some context to the map. I'm thinking this came from the Michigan Department of Community Health.
Yeah.
So there is a resource out of the University of Tennessee, in which there is, I want to get the correct name, the pediatric, let's see. The Pediatric End-of-Life Care Research out of the University of Tennessee, Knoxville. This was a grant-funded initiative, and it has a nursing research team that has culled together a lot of information for all of the states in the US. They have an advocacy tab, and if you click on that, you can get to the state's concurrent care, which is a view of all of the states where they're at for implementation of concurrent care for pediatric end of life. And Michigan has this report, which came out, I believe, in what you're looking at in 2014. And when you click on the state of Connecticut, what we have is something very minimal, which came out in 2010. So if you were to go looking for something like this table, we probably don't have it in our state because the research team out of Knoxville or University of Tennessee, they have searched through all of the state's Medicaid offices looking for their most current plan for concurrent care. So ours is stated Connecticut Medical Assistant Program, changes to the provision of hospice services, concurrent care for children effective March 23rd, 2010. It describes the Affordable Care Act, but we don't have anything more recent. So by brainstorming today of what we would like to see, I think we're going to end up creating it.
Okay. Does anybody in the team know the answers to these? Like if I were to say now, let's check the box, what would be the source for narcotics and analgesics?
Yeah.
Same for antiemetics. So you don't,
Depends.
so Yeah, I mean,
Yeah.
would we even know this? And maybe if somebody feels like they have enough information, just take a stab at doing that. And then we can go back and validate all the information.
Well, I
Well,
think-
it would be different for every diagnosis.
Okay.
You know, like, because, and Jessica's going to say this a lot better than me. It's because it, depending on what the terminal diagnosis is, depends on if that certain thing is being paid for by hospice or if it remains in concurrent care. And like I said, it could be two different narcotics. One can be paid for by hospice and one has to be covered by concurrent care. So I think, and Jessica, tell me if you have a different idea, that this needs to be disease specific.
I think that that's an excellent place to start because there are a lot of considerations that will go into whether or not, who's taking ownership of this area. But I think it even becomes more complicated when we think about where they're at in their disease trajectory, right? Might have somebody that's ventilator dependent, eligible for concurrent hospice care because of their underlying disease and the fact that if we remove the vent, they would probably die. And we're having those active goals of your conversation, but we're not necessarily going to be switching out all of their equipment. We're not going to manage the oxygen while they're on a vent. We're going to be keeping that all together, which I think that kind of plays in the disease criteria. But then we also think about an oncology child where they may be actively pursuing either palliative or aggressive chemotherapy radiation. It is very possible that the oncologist is going to want to maintain oversight of the narcotics because they do want to ensure that they're having consistency in how they're treating all of the symptoms related to the chemotherapy or related to the disease process. So I think that I really appreciate when these charts are used because I do think it's a really great vantage point to have on where we can delineate services and care, generally speaking. But I think we also want to make sure that there's that caveat that's provided to whomever this is intended for, whether it be the providers or the families or the legislators. Like, this is really more of a roadmap of what you could expect at end of life with a concurrent care patient, with the caveat that this could easily change depending on disease trajectory and types of, life prolonging measures that are in place. The other thing to think of is there's many, I am seeing opportunities for many more tabs to be included in this that we see often. Even within the DME tab, it's specialized seating and wheelchairs, sure, but there's also hospital beds. There's looking at different types of commodes and assistance with bathing and dressing. There's looking at all the different adaptive equipment that a child may be using for communication and where does that fall. Now, some of those are easy to understand where they fall, but a parent may not understand that. So I think that it also, this could become a much bigger thing, and that's probably why they kept it as simple as they did. But I think that's really what we're going to run into, is that there's a lot of complexity that really does depend on the individual, the circumstances, the diagnosis, the management. We, typically aren't going to be switching out oxygen right away upon hospice admission because it's very involved to be doing that when you've been managed by a pulmonologist for 15 years. So let's take our time and really navigate through those
100%.
communications. So
Yeah, and that's part of like the whole complexity, right? Of
Yeah.
even a parent understanding, because here's the truth of the matter too. They have this child at home, they have a hospital bed, they have oxygen, they have whatever there. Now they're going to sign on to hospice, let's say, to get more resources. And now all of those things have to now become under hospice. And if we don't have a contract with those DME providers, what has happened to us in the past, the bed gets removed, the oxygen gets removed, our bed goes in, our oxygen goes in. It's like, it's a very confused, just because we're being paid. Now, we have had some providers that will do a, a one patient contract with us. But that's potentially what we're looking at when all of this, starts to take place. This, like you said, Jessica, this could be a project in and of itself, right? But I think it's necessary to show the complexity.
I love what I'm sorry, go ahead.
I'm so sorry, Melissa. I was
No,
just
go
going to say that I think what would be helpful is actually taking out that last column of both hospice,
Right.
concurrent,
Yes.
and then in between hospice and concurrent curative service, have another column that is indicating like possible like transfer of care or dependent, care dependent on mitigating factors, something that also just indicates in some way why there might need to be individual accommodations if we're not necessarily going to build this out to meet every disease specific guideline. At least being able to highlight, when we are looking at narcotics, both technically can provide it, but that is going to be, based on individual assessment. We're always going to provide, I'm trying to find something on here. We're never going to provide IV fluids. Hospice is never going to provide IV fluids. So we don't need that checked off.
Right.
But there might be something else that we would always provide no matter what, like bereavement support. So we know that's always going to be checked off in the hospice category. So it's almost like just indicating where there is room for us to have those discussions, but also delineating without a shadow of a doubt, like hospice is never going to provide this, but concurrent services are almost never going to provide these things either, so that they can see how much more they could potentially get.
Right.
So I guess when I'm looking at this, I love all these comments because they're so very helpful, and it does emphasize the complexity of all of this stuff. I think if we can, and I think my goal was to come up with a visual for our report in February that shows the assembly and the folks observing, reading what we're trying to move forward, the level of complexity and why all this is so critical for us to coordinate under more or less a single umbrella, if that's possible. I think moving forward, we will need to be incredibly specific as we go forth with, coordinating, different services, different ownership, those types of things. So I think this could change into something, not its own project, but another level of detail, after our report or, on the way to our report and then following. Because I think all these things fit into the overall scheme of we need to create something easy for parents to manage and understand, and also easy for caregivers, medical professionals, practitioners to understand all the different coordination points. So I think that all this stuff fits very neatly under the concept of creating visibility and understanding and awareness, but also the importance of coming up with something that fits what we think our providers need. That makes sense?
Yeah. Yeah, and yes, it does make sense. And like when we think about where does palliative care, right? Because before, before hospice, is there a way? It's just like I just keep going back to palliative care being so important, and yet how do we make it more sustainable, like financially? Or is it that through CHAMP, palliative and hospice for pediatrics becomes the service? And I know I keep going back to that, and I'm looking for like this, the Emerald City here, but where you have a per diem, and maybe your per diem rate is much less if it's palliative care, and it gets more if it's more towards hospice, which is really, we have kids on our service who get a visit once every 14 days. We have kids on our service that get 3 visits a week. How we should be able to base our per diem rate on the need of the patient and family at that time, And with concurrent care, we shouldn't have to have them sign on that they're going to be dead in 6 months or less. And I just go back to that. And there we are with Champion Care, right? So, you know, more to come. And it's 1:57, and I wanted to give you guys some time back in your day and not make this an hour and a half. But does anybody have any other like remarks about, because I think we can kind of work on this a little bit, and I also think we need to talk about, and you know, everybody has their own websites, right? And even what would a family who gets a diagnosis like this start to look for? Because a lot of people today are going to go right to the internet, right? So what would they look for in the state of Connecticut? Would they think that they're going to go to the state of Connecticut website? Are they going to type in certain things and it'll lead them to a bunch of different websites? But I think the next thing to try and start thinking about is, where do we funnel all this information? And how does it become easy for a family to find this information and then, you know, try and be walked through on some of this stuff? And I don't know if anybody has any comments about that before we jump off.
Yeah, so I
Tony-
just want to say, this is Regina. I just want to say, maybe a place to start would be Info 211.
Okay.
Can we just go to the next slide, Peter? I just had a question for folks. Also. So I guess I'm thinking about our to-do items coming up. I think by January, there was discussion of having an in-person meeting. I'm thinking that we
Oh, Dr.
probably,
Moss, I'm sorry, Dr.
Yeah.
Moss today told me she has a room. I guess it's at Connecticut Children's, and she'd like to host the in-person. So more to come on that. I don't know like what room and where that is, but go ahead, Melissa. I
Yeah.
didn't mean to jump in.
No, that's fine. I think that's great, because I think we feel it would be best to sit across from each other and just go through things in detail. I'm hoping by that January meeting, we'll at least have a draft of the report that covers all of these things we've been talking about. And that's a little bit pie in the sky for me. But and then on the second meeting in January, we will have made edits between the January 7th meeting and the January 21st meeting. The other thing too, I don't know how people feel about doing a debrief with the advisory group in January on just what we're proposing. So that's something for everybody to think about. But also the meeting in February, it's just before we have to submit the report, just doing a final comment. So I think January will be a very busy month for us, just to do hard edits and hard comments and changes to whatever we're going to be proposing. So I just wanted to ask everybody's support. And I would like to follow up with people individually as I have questions about things, because I don't have subject matter expertise in these areas, and obviously all of you do. So there are going to be a lot of things that I probably won't understand or won't know about. So I hope I'll send you an email and see if I can grab, maybe half an hour, 45 minutes of your time if I have questions about something.
Tony and Melissa, can I just ask how much detail would be required regarding developing a workforce? Do you need a pretty hefty detailed plan, or?
I think, I don't know about the like how, in depth the plan has to be. I think that if we need any type of changes to happen, let's say like, okay, how do we get more nurses involved? Well, what we would like to see is an incentive for them to even do training in hospice and palliative care. So you may want to give them some kind of loan payment incentive or
Yes.
tuition incentive. So things like that. But I don't think we need to present the curriculum.
Okay.
I think it's just if we're recommending certain things like, okay, we have a staffing shortage, these are our recommendations to get rid of that staffing shortage.
Okay.
At one point we talked about, doing the Center of Excellence and being a pilot. And that's really a hard thing to get our arms around right now. So I think there's a lot of, and you and I can talk more about that because we're here and ready, but I think that we just need to, whatever recommendations we're going to put forth, I think we just have to be prepared to put those forward, especially if we're looking for changes or to put spas in or, things like that. And honestly, I think this is going to be a continued process.
Right.
And to
Okay.
that point, Barb, you had a comment, you and I had talked last week, and you had a comment about the continuation of this group and the importance of it. And I don't mean to put you on the spot. She's on mute. Barbara and I were talking, and she was mentioning the fact that assuming that we want to be successful in our venture here, that this team specifically are continuing to work on this will be vitally important to making sure things happen. Because sometimes things can drop off. I'm sorry, Barb, you came off of mute.
I was able to unmute. I couldn't hit the button quick enough, Melissa. Yes, absolutely. I think it's at least to think about the concept of, we have the Palliative Care Advisory Council. We have the MOLST Advisory Council. Is there a desire of this group to continue in some advisory or steering committee function, as we do with palliative care and MOLST, to kind of keep your eye on it so that there's always optics towards the problem?
Yes, 100%. And I guess when we're looking at a potential, recommendation, how do we put that in there? And we would have to look to you, I think, to, how would we put that forward?
Okay.
Great.
And we can certainly model the existing councils that are in place right now.
Yes. Yeah, 100%. Okay. Well, I'm tired. But I love this stuff, and I can't thank you all enough, because it's just so important, and it's such great work, and it's an honor to be part of it with all of you. So thank you again. And I also think, I know we've put dates out of other meetings, but we may actually reach out to certain individuals to do some ad hoc meetings, because I know we ask for a lot of time, but there are sometimes information that we need from certain people that we may just reach out and do it behind the scenes, and then get all back together at the actual meetings that are on the calendar. So thank you all. Elle emailed saying she was sorry she missed it. Something came up, and she'll catch up with us, and we will catch her up. So
Thank you.
Thank you all.
Yes.
Hey, have a great Thanksgiving, because I don't think
Yes.
we meet again before Thanksgiving. So have a great Thanksgiving.
Thanks,
You
everyone.
as well.
You
Thank
too.
you.
Bye-bye.